everyone, and welcome to this Toronto Notes QE1 High Yield Review series. Today's topic is routine immunization, and it's in the pediatric section of Toronto Notes. Again, like you may already know, I make this video to help you prepare for the QE1 exam, and it's not necessarily to replace your studying, but to use it when to listen to Toronto Notes when you're unable to read, to sit down and read. So you can decide to slow down the video, you can decide to listen to it over and over. Um, the text is all taken from Toronto Notes, and there are questions at the end to review what you've learned in the video. So let's get into the video today. It's a routine immunization. I'm going to take a few minutes to review the Ontario routine immunization schedule here. Feel free to listen to this part over and over to make sure like it sticks. So what immunization do kids get at 2 months? Let me go through the schedule. The schedule is children in Ontario, they're vaccinated at age 2 months, 4 months, 6 months, 12 months, 15 months, 18, 4 to 6 years, at grade 7, and at 14 to 16 years. I'll go through that again. 2, 4, 6, 12. That's 2 months, 4 months, 6 months, 12 months, at 15 months, 18 months, then between the 4th to 6th year birthday, either on their 4th birthday or after. So not earlier than their 4th birthday. Then at grade 7, then between 14 to 16 years. So now let's go to what you get at the 2nd month birthday. So when children are 2 months, what vaccination do they get? They get the Pediacel. That's the D-TAP that has IPV and HIB in it. They get the Pediacel. It has the D-TAP, that's diphtheria, tetanus, pertussis, and it also contains the IPV for polio. It also contains the HIB, that's the Haemophilus B vaccine. So that's a pentavalent vaccine, 5 things. So they get at 2 months, they get the Pediacel, D-TAP, IPV, HIB. And they also get the Prevnar 13. That's for the pneumococcal vaccination. And they also get the rotavirus. So they're getting a total of 7 antigens at age 2 months. Then at age 4 months, they're going to get the same DTaP, IPV, HIB, and they will get the pneumococcal C13 and the rotavirus as well. Then at 6 months, they will get exactly the same thing except the pneumococcal C13. So between first 3 visits, 2 months, 4 months, 6 months, they're getting almost exactly the same thing. But at age 6 months, they will skip the pneumococcal C13. I hope that's clear. Then when they come back at the 12th month birthday, they'll be getting the pneumococcal C13. Then they'll be getting the MMR, that's the measles, mumps, and rubella vaccination. It's called Parix or MMR2. And then they get the meningococcal C vaccine. So age 2, 4, 6, 2, and 4, they get DTaP, HIB, and IPV, pneumococcal C13, and rotavirus. 6 months, they get DTaP, polio, DTaP, HIB, IPV, and rotavirus. 12 months, they get the pneumococcal C13, they get the MMR2, and they get the meningococcal the meningococcal C, yes, the meningococcal C vaccine. So that's at 12 months. Note that at 12 months, they have to be exactly 12 or after the 12 months. So they have to have had their first birthday either on the day of or after. Then at 15 months, they get the varicella, that's the chickenpox, varicella vaccine virus, chickenpox vaccination. Then they come back at 18 months to complete the series for diphtheria, tetanus, pertussis. So that's the DTaP, IPV, HIV. So DTaP, IPV, HIV is taken at 2, 4, 6, and 18 months. So the final one, they get it at 18 months. And then they come back after their fourth birthday between the ages of 4 to 6 to get DTaB IPV. This does not have the HIV in it. So they come to get the DTaB IPV. They also get another dose of the MMR, that's MMR, plus the varicella chickenpox. So two shots, but the first shot is composed of DTaP IPV, and the second shot is composed of MMR plus varicella. That's a chickenpox. Then at grade 7, they come to get the meningococcal vaccine, and the hepatitis B and human HPV vaccine for girls. And then at 14 to 16 years, they get another DTaP, but this time does not include the IPV. So that's it. It's a lot to remember, but I want you to play and replay this part of the slides until if you shut your eyes, you can remember, because it's so important to remember this as a physician practicing here in Canada, what vaccine a child will need at what age. All right, so let's go on to additional notes about adverse events. There's a long list of very important adverse events to that is associated um, with each vaccination. But as a physician, what you must remember is that adverse events must be reported to the local or regional health unit when the event you confirm that it has a temporal association with a vaccine. So it's after the child got the vaccine that they developed that adverse event. There's no other clear cause at the time of reporting. So, for instance, a child bleeds and the child was playing and it was hit, there's a reason for that bleeding. There must be no other clear cause at the time of reporting, so it can be properly investigated, and it meets one or more of the seriousness criteria and is also unexpected. It's also good to note when you are in practice how to store vaccines. They're all generally stored between 2 to 8 degrees Celsius. Generally, any additional um storage information for any vaccine is included. So if it's going to be a different temperature, you will get to know it when you receive the vaccine for storage. Then there are also like modifications to this routine vaccination schedule that I've spelled out. There are modifications to it. When there's a newcomer coming into Canada, for instance, and they've not been previously immunized or they're missing their vaccine records, you use the catch-up immunization schedules for newcomers. For children not previously immunized, maybe the parent was refusing vaccine before, but now they're ready to get their vaccine. You don't use the regular vaccine schedule. You use the catch-up immunization schedule that tells you this is what you can give at this age. Then there are additional immunizations for children that are at risk due to their underlying medical conditions. So, a child with sickle cell disease, for instance, a child with asplenia, for instance, there are additional immunizations that are needed for those children. Then there is also the current Ontario catch-up program for HPV vaccines. So, they're giving 2 to 3 doses for grades 8 to 11 for the boys and grades 8 to 12 for the girls. So that's important to note as well. Now, moving on to immunization for immunocompromised patients. This is really important because um, they are susceptible to infection, their vaccine response time varies. So that's why it's different to how to vaccinate them is different. You don't generally follow the immunization schedule. So, first thing to note is that they are susceptible to infection differently. Their vaccine response varies. So you give them the vaccine, you don't just automatically assume that they can be given the vaccine at any time and they would respond to the vaccine the same way. And so the vaccine schedule for immunocompromised patients is based on their current immune status. So it's individualized. Now, what do you do when it's time to administer? What do you keep in mind when it's time to administer inactivated vaccines? They may be administered if indicated, but the responses may be reduced or absent, and the duration of immunity may be reduced. So, for those cases, they may need an increase in dose or they may need extra booster dose to extend the duration of immunity. So that's what to keep in mind for inactivated vaccines. For live attenuated vaccines, we've always been taught that for immunocompromised patients, there are considerations for live attenuated vaccines. So if the patient is severely immunocompromised or if you're uncertain of their immune status, like for instance, you've not checked the CD4 levels, the IG levels, you're certain of the immune status, the current immune status, you must avoid live attenuated vaccines. For patients with isolated IgA deficiency or IgG subclass deficiency or complement deficiency or asplenia, live attenuated vaccines can be given. So I want you to take note of these considerations because it's not a blanket avoid live attenuated vaccines for all immunocompromised patients. And that's why from the start, the consideration is you individualize the vaccine schedule based on their immune status. So if the patient has phagocytes or neutrophil disorders. Then for live attenuated viral vaccines, so live attenuated viral vaccines are okay for patients with phagocytes or neutrophil disorders. But for live attenuated bacterial vaccines, they are contraindicated. So I want you to take note of these considerations. Now, like we said before, they may need some other vaccines that are not usually recommended for healthy children or not usually administered beyond a certain age. So that's also something to take note. They may need vaccines that are not usually are administered at a certain age. They may need it later than others. So the timing for their vaccination is individualized as well. The type of vaccines they get is individualized. Vaccines should be administered when the maximum immune response is expected. That is when they're not immunosuppressed medically, pharmacologically, or they've just gotten a transplant. Their response may also vary. So, usually, if it's possible, it will be great to do um, a post immunization antibody titer if it's appropriate to check for the immune response to that vaccine. So, those are considerations to note for immunization of immunocompromised patients. Now, let's go on to talk about vaccine hesitant parents. This is really important, and questions on this come out when you're learning about motivational interviewing. How do you talk to patients? So, vaccine hesitant parents, the Toronto Notes wants you to know that how you provide advice plays a key role in parental decision making. First, you do not dismiss vaccine hesitant families from your practice. That's a no. Then it's advised to use a presumptive approach assume and then do motivational interviewing. If you've watched videos from the primary care playlist, you will understand what I mean by motivational interviewing. You can go back and watch that video. Use open ended questions, listen to their concerns and opinions, and do not assume the health concerns. So, use open ended questions. Please explain what are your reservations so they can express themselves, then address the concerns that they've outlined in a non judgmental and non confrontational way, and validate why parents may hold their beliefs. Use compelling stories of vaccine preventable disease. Communicate clearly to discuss the disease risks and vaccine benefits and risks. Address immunization pain, concerns about pain. Discuss options for pain reduction like breastfeeding, rubbing or stroking the skin near injection sites, and distraction techniques. Talk about community protection as an advantage for vaccinating their children, and also let them know that the wait and see approach is not advisable. Then promote altruism. So, not receiving vaccination can have consequences for others that are around the kids. Now, let's go on to other considerations. When you've had this conversation with the parent and they still refuse to immunize their children, please, you must inform them about the associated risks of diseases and responsibilities, which include that they must take more additional steps to protect their children from acquiring illnesses. So, like avoiding sick contact, they must also note that not vaccinating risks the health of others. They must inform healthcare professionals of the lack of vaccination when the child is sick, so that additional measures can be taken by the healthcare professional. If a vaccine preventable disease is in the community when there is an outbreak, the parents must know that they're required to stay away from school, consider disease specific risks. They must know what symptoms to look out for. They must also know that tetanus has a greater than 10% mortality and there's no community protection for that. So the benefits that non-vaccinated children may get when other children are vaccinated is not available for tetanus, and there's a greater than 10% mortality. Also, they must understand how they may be refused permission to travel, especially when they're vaccine specific to geographic regions. So these are considerations when the parents refuse to immunize their children that they must know. All right. So I found this really cool clinical pearl in Toronto Notes that I wanted to highlight here. It's on the effects of rotavirus vaccination and diarrhea outcomes. So, the results from this study showed that rotavirus vaccine was found to be effective and efficacious across all regions. It prevented rotavirus diarrhea, severe rotavirus diarrhea, and rotavirus hospitalization. It also reduced hospitalization in general and severe diarrhea. So, that's one um, clinical pearl that I found in Toronto Notes and I wanted to include here. Let's go on to some practice questions. Question one: a child with a significant immunodeficiency requires routine vaccination. The child's parents ask, can all the vaccines be administered as usual? What's your answer to this parent? You can pause here and pick the right answer. The answer, of course, is C. We're going to individualize the vaccination schedule according to the child's immune status. So you're checking what's their immune status. Is this the best time to give them this? Will their immune system respond? In terms of scheduling as well, in terms of the type of vaccines they get, is it okay to give them this live attenuated vaccine or not? So it must be individualized according to the child's status. Next question: a severely immunocompromised child is due to receive a vaccine. The parents want to know why the physician is concerned about whether the vaccine is live attenuated or not. Which of the following is the most appropriate recommendation for this child? I'm pausing for you to pick the right answer. All right, A is the most appropriate recommendation. It should generally be avoided in severely immunocompromised patients. But of course, there are considerations that we've described earlier. So we must remember all of those. Question three: a child with an underlying medical condition is being assessed for immunization. The physician wants to determine the optimal timing for vaccination. Which of the following principles is most appropriate? B is the answer. Vaccinate when the patient is expected to have the maximum immune response. Question four: a 6-year-old child has no reliable documentation of previous immunizations after recently arriving in Canada. Which of the following is the most appropriate approach? The answer here is C. You use a catch up immunization schedule. So the child is 6 years old and there's a way to give the vaccine at that age. It shouldn't just be you restart from age 2 months. No, you use the catch up immunization schedule here. Question five: a parent tells the physician, I don't want my child vaccinated. I've read a lot online and I'm still not convinced. Which physician response is most consistent with the approach we've described from Toronto Notes? The answer is C. What concerns you most about having your child vaccinated? Here, you're being open minded, you're asking open ended questions. Question six: a parent refuses to vaccinate their child and says, if my child gets sick, that's my responsibility. It doesn't affect anyone else. Which of the following is the best point to emphasize? The answer here is B. Unvaccinated children can increase the risk to people with weakened immune systems and other vulnerable individuals. So that's the end for this um, video on routine immunization from Toronto Notes. If you're studying for your QE1 exam, I want you to stick around, like this video, follow the YouTube channel, and add the playlist to your YouTube so you can have easy and quick access to the videos. Thank you very much, and I'll see you in the next one.